Hi, myself Dr. Vishwanath, consultant physician and diabetologist. Today I called to ask few questions with Ravishankar. He's a senior urologist and transplant and robotic surgeon. So many people have a common misconception about what urologist will do and what nephrologist will do. To clear that common this one, urologists are the ones who deals with the surgical part of the kidney. Anything related to surgery, whether it could be your kidney stones, whether it could be a kidney transplants, or cystoscopy and all. Nephrologists are the ones who deals with the medical part, like a dialysis and medical management. So with this clarity in that, I'll ask Ravishankar and also welcome to the show.
Okay, sir.
So let it be informal. We're asking questions mainly to create some awareness on the public. So when somebody have some surgical issue or something, they suddenly get anxiety. They don't be knowing many things, and some people think that their questions are silly.
Yes.
But actually they are not. They have so many common misconceptions. They want to clear it out. So this video might help them.
Sure.
So start with, what are the common urinary symptoms like people consult urologist?
So usually the people present with flank pain. The pain starts from the flank and radiates to the groin. This is typical of ureteric colic or kidney stones in the kidney or the ureters. The other common symptoms with which they come with are frequency of urination, which is more common in the night. We call it as nocturia, and poor urinary flow and the sensation of incomplete voiding. These are the symptoms with which they present with for UTI and prostate. Even benign enlargement of prostate also presents with symptoms like this.
So you said the flank pain. The flank pain is exactly here, no?
Yeah.
So if somebody is having this severe flank pain, so what would the possible differential diagnosis? What all the things can be suspected?
So usually the ureteric colic is unbearable. So we tell the patient that it will be similar to a labor pain. So the pain will be extreme and patient cannot sit, cannot stand, cannot walk, cannot do anything. So this is
somebody having a severe flank
pain starting from the flank and radiates to
so need to consult immediately and they have to undergo scanning.
Yes.
So mainly to rule out kidney stones. So this is an important message. So many people understand that the abdomen too many areas are there. Remember the flank pain. You have a severe flank pain, but don't diagnose yourself and get a treatment. This is a thing that you have to consult a doctor, a urologist, and then get a scanning, and accordingly the treatments. There are various modes, where the stone is and all. All the stones are the same treatment. It only indicates that there could be a kidney stones.
Yes.
And nowadays, even in my physician practice, many people like the sugars are under control.
Yes.
Still, the frequent urination.
Yes.
Like have a frequency of urination. Some people have frequency of urination in the night. So we know that diabetes can cause polyuria in the night.
Yes.
So apart from diabetes, so what are the other causes? The causes of frequent urination.
So as you told, in diabetes, polyuria is one of the common symptoms. So when the sugars become more, they start excreting in the urine, and naturally patient will present with frequent urination. So when sugars are there in the urinary system, it acts as a nidus for infection. So that will cause urinary tract infection. So UTI is one common condition causing frequent urination. The other common condition in the elderly, especially more than 50 years age group, is prostate enlargement.
In the middle-aged people, many middle-aged people.
UTIs, commonly UTIs.
UTI. Anytime some people say in the office, they have a tendency to go for a frequent urination. Is the stress or anxiety also have a
Yes, that is called psychological polyuria. Some people do have that.
Okay.
So they take a lot of water and have the tendency to go to urination frequently. That is psychological more than anything else. And in these patients, we have to rule out UTI as well. In these scenarios, there is a chart called urinary chart, 24-hour urinary table. So based on that, we will get to know whether how much urine patient is passing, how much fluids he is taking. So based on that, we will differentiate the organic cause of UTI and a psychological cause of polyuria.
So somebody comes to the OPD with a complaint of frequent urination. So apart from ruling out of this diabetes and UTI, what are the other tests to be done?
So to rule out prostate enlargement, we have to get a Uroflow test, ultrasonography, and also urine routine test. These are the three
So the
common
common
tests.
thing we have seen that whenever urologist write a ultrasound scan, so they write a pre-word and a post-word scan.
Yes.
So what is exactly the significance of it, and what information you get through that?
So why we suggest that is because sometimes the radiologist may miss giving this information, which are very helpful for us in diagnosing. So pre-void and post-void is, in common terms, the amount of urine which the patient has in his bladder before passing urine, and post-void is how much is remaining even after passing urination. So ideally in prostate enlargement causing obstruction to the urinary tract, naturally there will be more post-void urination. So we specifically ask the radiologist to mention about the post-void residue, so that we will get an idea whether the patient is completely emptying the bladder or still there is some residue left behind.
Okay. So what is a normal post-void urine usually?
So it is subjective actually. So less than 50 ml some people say,
Okay.
some people say it should be less than 10% of the pre-void volume. So if the pre-void volume is 600,
Any average value? Average value?
50, some people consider as 50, some people consider it as less than 10% of the pre-void value.
So after passing during post-void, if somebody is having more than 50 ml, that is significant. They have a
Or
problem.
more
with
than 10% of the pre-void volume.
Okay. So nowadays we see many women comes with recurrent UTIs. Some of them are diabetic, and it's really frustrating. And they get urine infection every 1 to 2 months. Cultures keep positive. Many times, like over a period of time, they will become like a drug-resistant UTIs. So what are the in such cases of recurrent urine infection? From the urological point of view, what are the tests to be done, and what should not be missed?
So in females, all age group of females have a higher risk of getting a UTI whenever they are sexually active, and after menopause also they are prone to get UTIs compared to males. So as sir told, in females, because of the misuse of antibiotics or irrational use of antibiotics, the resistance of antibiotics is so common because of UTI. So the next episode which they get will be multi-drug resistant. So it is imperative to treat the UTIs properly in the first setting and to prevent getting a recurrence in, especially in women. So in females who are getting such recurrent UTIs, we have to rule out any cause, structural or functional abnormality in the urinary tract. So based on that, if there is no structural or functional abnormality, it is called uncomplicated UTI. It has to be treated for a longer period of time, and in some cases patients who are having recurrent UTIs like twice or thrice or 4 times per year, we do put them on a low course antibiotic prophylaxis for a longer period of time, so that the bacteremia will not happen. So that
So longer period means how long you can give antibiotics?
some patients we have given for 6 months also.
Daily or
Daily.
Okay.
Half dosage it is, not a full dosage. It's a maintenance dose. Commonly we give nitrofurantoin.
100 mg BD will give
100 mg OD we will give.
continuously
try
6 months.
Continuously for 6 months.
6 months.
Or even Bactrim DS trimoxazole also can be given.
OD dose. Also.
OD dose for 6 months. Usually I give for 6 weeks and see. If they don't get, if they are responding well, if they don't get UTI, I'll ask them to continue for another 6 weeks and
So
another
anything to
3 months like that.
deal with decline in the estrogen, the post-menopausal
Yes. So especially in postmenopausal women, lack of estrogen is one reason why they will get recurrent UTI. So especially in this age group, we usually give a estrogen supplement as well. So it comes in the form of an ointment or a gel which they have to put in the vagina. So in the surrounding the urinary passage, they have to apply in the vagina to prevent atopic vaginitis, which is one of the common cause for UTIs. And along with that, to prevent recurrent UTIs, adequate hydration is one thing, strict control of sugars is one thing, and maintaining ideal body weight and avoiding constipation, all these contribute.
So you said that we have to use antibiotic rationally.
Yes,
So
exactly.
in which cases there are something like a urine routine is showing pus, and sometimes where antibiotic dose is not required,
Yes.
warranted. What are such conditions?
That is called as asymptomatic bacteriuria, wherein the patient is showing all the signs of infection like pus in the urine, turbid urine, all these things, but the patient is completely asymptomatic. So these are the conditions where you have to avoid antibiotics.
Because we have seen in the many health check patients,
Yes.
they come as the urine routine is showing the 15, 20 or
Yes.
something many pluses,
Mm.
but they absolutely don't have the symptoms.
No need to treat them.
So in such cases,
Antibiotics-
culture is also not required.
Not required. If they are not having symptoms, basically it's not required.
So the pulses alone is not a
Not
indication to start
indication, yes.
antibiotic. If no this one, no need to treat.
No need to treat.
Next, we'll start some very important urological issue, the prostate. Okay, and now like recently news that Joe Biden has a prostate cancer now, and prostate cancer is becoming one of the top 10 cancers in men. So keeping that in mind, so when you suggest that as screening for a prostate cancer at a BPH, at what age you must screen, and what are the simple tests or simple examination where it has to be screened?
So, as you told, prostate cancer is increasingly becoming very common in our country. But unfortunately, in our national program, there is no prostate screening test. But nowadays, routine health checks, which is done in all private labs, cover PSA. So, ideally, we have to do screening for prostate cancer. That's a basic test called blood test called serum PSA, which needs to be done for all males over 50 years of age. So if the patient is having a higher risk of prostate cancer, if a family history is there, if a brother, father is having, then they have to start undergo screening from 45 years of age. The common ways of diagnosing or screening prostate cancer is by getting a simple blood test called serum PSA and to undergo a digital rectal examination by a urologist.
So this what is the two things, no? Total PSA and a free PSA.
Yeah.
So which one is suggest to be more specific?
First thing we suggest is total PSA. Free PSA we suggest when there is a gray area between the PSA value. We call it as gray values between 4 to 10 as the gray area. In those scenarios, we suggest free PSA. But ideally, first test we prescribe is total PSA.
Total PSA only.
It should be ideally less than 4.
And in India, see there are some category of people who frequently undergo annual health checkups
Yes.
to get a PSA covered. And there are some category of people, they are Sankata Bandaga Venkataramana.
Yes.
Unless they have some problem, they never visit hospital and they think that everything is okay.
Yeah.
In such people, like you suggest like how often, once in a year or twice in a year, to go for a PSA and what?
So prostate cancer is a very indolent cancer. It won't give
And to
symptoms.
be
in the-
precise, like unless they have symptoms, they don't
Yes.
come to hospital. So in prostate cancer have some symptoms, or some people can have without symptoms also.
Yeah, usually they don't present with symptoms. So that's what I was going to tell. It's an indolent cancer. Patient will not have symptoms, still it has spread all over the body.
This is very
So-
important point to be noted.
Yeah, so ideally all men have to be screened over 50 years of age with a PSA. So otherwise if we wait for the symptoms to appear, you may have reached a stage 3 or stage 4 prostate cancer where the treatment is palliative or supportive care. So rather than waiting to get symptom, you ideally get screened after you are 50 years old.
So normally you say the PSA value more than 4 is significant.
Yeah.
So what is the value significant for a BPH, benign prostatic hyperplasia and prostate cancer? Anything
So
specific value?
PSA is an organ specific test, it's not a disease specific. Means it doesn't differentiate between infection and cancer. So there lies the importance of clinical examination as well. So PSA can be raised in infection as well as cancer. So it has to be complemented with a digital rectal examination. PSA test alone will not make a diagnosis of cancer.
Okay. So somebody is having a high PSA and next step is to go for a digital rectal examination by a urologist.
Yes.
So after these things, suppose somebody is suspected to be having cancer. So instead of going for a biopsy,
Yes.
so nowadays there is multicentric MRIs.
Yes.
So what is your opinion on this, on your clinical experience?
So for PSA levels of more than 4 and less than 20, patient needs to undergo something called as multi-parametric MRI of prostate. So with this, we will get an idea. It gives a score called as PIRAD score. PIRADs 1, 2, 3, 4, 5. So based on the PIRAD scoring, if it's 4 or 5, definitely they have to undergo a biopsy. Or if it's PIRADs 1 and 2, they need not undergo a biopsy.
Okay. So now the one thing is like you don't need to be scared about a biopsy. There are some cases you can avoid biopsy, you can diagnose it properly with the
Yes.
MRI also,
Yes.
MRI prostate also.
Yes.
And come to the treatment, like that's a fear. Somebody is diagnosed with a prostate cancer. So suppose somebody is diagnosed in early disease. So what is the treatment options? And somebody died with a late disease, it already spread to other organs. What is the treatment option? What is the prognosis?
So over the last 10 years, lot of development has happened in the field of prostate cancer. So the ideal treatment in a very low risk and a low intermediate risk is a robotic radical prostatectomy, which is a curative treatment. So this is for locally advanced and localized disease. For prostate cancer which have spread all over the body, usually it spreads to the bones and sometimes to the viscera. So in these patients, androgen deprivation therapy and hormonal therapy and chemotherapy based on the extent of spread are equally effective.
Okay. So where was the role of surgery will come?
So low risk and intermediate risk,
Surgery
has a curative role.
You can already advanced.
Yeah.
The surgery has no value than hormonal chemotherapy.
Yes.
Has some. So like what is the survival rate? How many years people will survive?
They usually survive once the curative surgery is done. They usually survive their lifespan. So as I told, prostate cancer is an indolent disease. It won't change the lifespan of the disease. Usually patients die of other conditions like coronary artery disease or something else rather than due to prostate cancer. Prostate cancer per se will not make the patient die. It's very rare. So usually patient live their full lifespan, and curative procedures like robotic radical prostatectomy help them to live their normal life.
Okay. So as a doctor, you're working in a medical hospital. So what are the preventive measures you keep telling your patients in terms of the screening, in terms of lifestyle, so that they can prevent prostate cancers?
So ideally, screening test is one thing which we have to undergo. All males over 50 years undergo a simple test called serum PSA. Meet a urologist, get a digital rectal examination, have a very good lifestyle in terms of food habits, have a good diet, and maintain a healthy lifestyle, avoid sedentary lifestyle, and maintaining ideal body weight. All these helps.
So to come to my area, is there any connection between the diabetes and prostate?
No direct correlation.
No direct correlation. Okay. Now the ED, erectile dysfunction, is one of the common problem in many men above the age of 30, 35, 40, and many have a proper reasons, like many have uncontrolled diabetes, and some people diabetes under control, still they have this erectile dysfunction. So they have erectile dysfunction has multiple angles. One, it can be psychogenic, it could be vascular, or it could be something else also. So in terms of the urological point of view, so what you can evaluate when somebody comes with erectile dysfunction?
So sometimes what happens is many of the patients who come to me already they would have taken over-the-counter medicines which are available in our country. So ideally it should not be given. So what happens is in
So you mean to say that something similar to Sildenafil, Viagra, Tadalafil, other people are used to use them. So that they should not be used.
They should not use it.
Because there's a very important message. They should not be used before a proper evaluation.
Exactly.
Even I have seen that many uncontrolled diabetes, they keep using that.
Yes.
So what is the purpose? It's not treating the root cause and all. So what have to be evaluated?
So also one more thing is when they take over the counter, the dosage will not be titrated. Some pharmacist may give 25 mg, 50 mg, whatever he knows. So what happens is there is a phenomenon called tachyphylaxis. So wherein the same dosage will not be effective when he takes the next time. So that's what is happening with the irrational use of over-the-counter these medications. So ideally they have to meet a urologist or andrologist and undergo a proper evaluation. Ideally we take a history of the patient, whether it is when it started, how it started. Some people give a history of only 6 months, 1 year. So what on further evaluation we will get to know that he is having some interpersonal problems with his wife. So these are some of the common.
Could be psychogenic.
Yes. So in this scenario it will be psychogenic. So there are other causes of ED as well. So metabolic causes like hypothyroidism, uncontrolled sugars, yes, and vascular causes like atherosclerosis, neurogenic causes like multiple sclerosis, Parkinson's, all these needs to be evaluated. So once we rule out all these causes, once we get to know it is psychogenic or the underlying cause is hormonal, based on that we can give a proper treatment. But
So what are the
majority of
urologically, what are the options available for its
so
treatment?
commonly the over-the-counter medicines like phosphodiesterase 5 inhibitors, sildenafil, tadalafil, avanafil, if given in a titrated dose, it has a very good effect. If these things are not working, then there is intracavernosal injections of pepaverin and bimix, trimix injections are available. Vacuum erection devices are available. So in all, if all these treatments fail, there is also penile implant procedure. So which will give a
So is there
erection
any
to
role
the
for this
patient.
penile Doppler test
Yes.
to know the blood flow?
Yeah.
And then which category of patients need a penile implants?
So penile implant is ideally given is the last treatment of choice. When all these modalities fail, we suggest them penile implant. Obviously, while evaluating, we will rule out the hormonal causes, we will rule out vascular causes with the Doppler. So after ruling out all these causes only, we will further go for the treatment. So if all the modalities fail, then we have an option of penile implant.
So how many years it will come, like?
So usually it comes for around say 5-10 years based on the usage.
Now with regard to the kidney transplants, now compared to 10 years ago, now the kidney transplant has become more common.
Yes.
So as you know, the nephrologist will maintain the medical part. The primary surgeons who do kidney transplant are urologists and transplant surgeons. So what is your experience and what any advances? What are the things you need to hit to the public? Because many people think that they have some fear also. So transplant means it is some completely big thing.
Yes.
So let's not avoid. Let's not go for it. That's also the misconception among the people.
Yes.
So what is your advice on this?
So I have been part of nearly 500 renal transplants over the last 5-6 years. So kidney transplant is definitely a life-changing moment for the recipient. So you are giving a new lease of life to the recipient. So in live kidney donation, usually the relatives, mother, father, brother, sister, wife, husband can give. So in India right now, live related transplants are the highest in number. But in foreign countries, cadaveric renal transplant, they do highest number of transplants. And with regard to outcomes among all organ transplants, kidney transplant has the highest success rate.
So this is another thing because
yes,
compared to liver transplant,
liver, heart, lungs, whatever you take, kidney transplant has the highest success rate, close to 90 to 95%.
So what this is again the cost is another thing. What is the normal cost in a hospital like in a good corporate hospital like Manipal?
Yeah, if it's a live related renal transplant, so usually the cost comes between 8 to 10 lakhs.
That's compared to the liver transplants and all, it is
Liver transplant is almost 4-5 times
4-5
higher
times more than this. The kidney transplant is one of the common transplants, and as what is the cadaveric is good or live donor is better.
So in ideal scenarios, live related transplant results are better. But because of the lack of donors, so sometimes we have to go for cadaveric renal transplants. So the problem with cadaveric renal transplants is, one is it is done in an emergency situation. The donor, the deceased donor may not be ideal, he may be having diabetes or something like that. The ischemia time is more and the results are little bit lesser compared to live related transplant. But live related transplant or cadaveric renal transplants, whichever is available based on the scenario, it is better to undergo a transplant rather than going through dialysis lifelong.
This is very important. Instead of going to lifelong dialysis, kidney transplant is one of the important things.
So when you have a better option in the form of kidney transplant, you have to go for it. You talk to a patient who has undergone dialysis, who has been undergoing dialysis and who later get a kidney transplant. It will make a massive difference to his lifestyle, the quality of life, everything. He'll be very happy.
How much time it will take for you to OT regarding kidney transplants? What are the important preparations has to be done?
So in scenario of live live related renal transplants, so we usually start with the one team will start with the organ harvesting, the other team will prepare the recipient for the surgery. So once everything is ready, so we remove the kidney and implant it to the bed. So usually it takes around 5 to 6 hours.
5 to 6 hours surgery. Okay. This is like kidney transplant over the last few years. It has been a lot of the people also accepting it as a this one.
Yes.
And it is even compared to other transplant, it is not too much expensive.
Yes.
So it is can be done in 7 to 8 lakhs, nowadays 7 lakhs.
Yes.
So people should consider kidney transplant to avoid a lifelong dialysis.
So over the last few years, the government has also taken many steps so that the organs are not getting wasted. So you can also enroll to donate your organs. So if at all you enroll to donate your organs, so whenever the situation happens, your relative informs the authority, they'll come and evaluate the patient, and if possible they'll take liver, 2 kidneys, lungs, heart, corneas. So it will give a new life to at least 5-6 patients. So even in death you can do a noble gesture. So going forward, our country, there is a lot of difference in the donation pool and the organ requirement pool. So cadaveric transplants has to become more robust in our country, and that will solve the problem of transplants. And also many needy patients will get the organs and they will be free from the dialysis and they'll have a good quality of life.
Okay. So this is about kidney transplant. In next section we can discuss about robotic surgeries in urological conditions. Now this section will discuss about robotic surgeries. Nowadays it is a trend that there is people are thinking earlier about laparoscopic surgeries, then robotic surgeries, and some people are in a notion that robotic surgery is something like a elite. And I want to confirm with you that what are the common places where robotic surgeries are indicated, like the common indication, and in wherein it's not required. You can go for a normal surgeries also.
So over the last 10 years, robotics has revolutionized the way surgeries has been done. As I told, there are some areas where it has definitely made a difference. There are some places where it is not required. So for places like deep organ, for example, say pelvic organs, the robotic transplant is it has revolutionized and it has given very good results compared to laparoscopy or open surgery. But in terms of urology, radical prostatectomy is one thing where it has made a difference. Partial nephrectomy is one surgery where it has made a difference. Reconstructive surgeries like vesicovaginal fistula, PUJ obstruction, pyeloplasty, these are some of the procedures where robotics definitely is useful. So there are other conditions like if the patient needs a simple nephrectomy or a radical nephrectomy or a adrenalectomy, robotic will not give much more advantage than laparoscopy. So in these scenarios, laparoscopy is equally effective. But in pelvic organ procedures like say for example radical prostatectomy, vesicovaginal fistula repairs, partial nephrectomies, robotics has definitely an added advantage.
Okay. So one is regarding the compared to the regular laparoscopy, the robotic has little more costlier.
Yes.
And apart from these metros like in Bangalore, Manipal, we have access to robotic surgeries. In a tier 2 cities like Tumakuru, Shivamogga, in such places where there's very few places have the robotic surgery.
Yes.
So in such places, like in future, do you think this is a necessity?
Yeah, definitely it will come. It's just like another modality, like laparoscopy also initially it was available in metros, gradually it percolated into tier 2 cities, tier 3 cities. Even now the same thing is happening. Right now Mysore is having one robot apart from Bangalore. I'm sure definitely over the next 5 years it will percolate to many more tier 2 cities as well. So and it is definitely helpful for some of the procedures. Going forward, I know cost is one consideration right now, but going forward, and one more thing is now a cheaper and effective Indian-made robot is also in the market. So that has significantly reduced the
Regarding
cost.
the cost is why robotic surgery is expensive, because robot is expensive.
Yes.
So what is the cost of approximate robot for this?
So
Use the same Da Vinci or something else?
Da Vinci robot has many generations. Usually it will cost around 16 to 18 crores based on the generation. So there are newer Indian made robots, Chinese made robots, which are much cheaper. They are available at 5 crore and 6 crore. So as I told, gradually it will become much more cheaper, and once it becomes cheaper, it will be affordable to all sections of people in tier 2, tier 3 cities also. And we can have this facility in tier 2, tier 3 cities as well.
So like hospital is investing 16, 18 to 20 crores for the robot, we can't expect the surgery to be done at a cheaper rate.
Yes.
But the thing is, people should understand that, discuss with the urologist, wherever the robotic surgery is not useful,
Yes.
not 100% indicated, you can avoid it, go for the
Definitely.
normal surgeries to avoid the cost.
Yeah,
It is not like that robotic surgeries show your status level or something advancement. There are something somewhere it's not required.
Not
There-
required.
Urologist's opinion and his experience also matters.
Yes, so you take an opinion of your urologist. As I told, there are some procedures where robot definitely has an advantage, and some procedures where you can also do a equally good laparoscopic procedure. So take an opinion of your urologist or the concerned surgeon and decide accordingly. So with regard to urology, robotic radical prostatectomy, robotic partial nephrectomies, robotic VVF repairs, robotic pyeloplasties, robotic radical cystectomy and ileal conduit, all these procedures robotic definitely has an advantage, and you can go for it.
And common thing is, what is the time duration? For example, same surgery in a robotic surgery and same surgery with a normal. So which takes more time?
So to be honest, robotic takes much lesser time because of the degree of movement, the dexterity which the surgeon has, the magnification of the vision and less blood loss. So the procedure becomes much more easier for the surgeon, and in terms of recovery, blood loss and outcomes also, robotic definitely has an advantage. So compared to laparoscopy, there may be little bit difference in the robotic surgeries, hardly sometimes in cases of prostatectomies and partial. So there is definitely, it will save some time. Rather than the time, it is the precision, the magnification and the outcomes are good with robotic surgeries.
And common thing, many of my technocrat friends keep asking, in future, when robots can do surgeries, okay, what is the relevance of surgeons then?
No, that is not going to happen. So the common misconception which people has is robot itself does the surgery. That is not.
This is a common misconception. They think that
Yeah.
you just fix it and leave it.
Yeah.
The robot is surgery.
No. Robot has arms which are inserted into the abdomen, and surgeon will be controlling the robot. So the surgeon controls the robot. All the movements of the robot will be controlled by the surgeon. So it is the surgeon doing rather than the robot, and robot is just a modality of doing an effective procedure.
So
in an
in
effective
the
manner.
future, it's advancement of AI, technology and all. Now you fix it, and throughout the surgery, you do the surgery.
Yes.
Even though it's a robotic, you assist throughout the surgery.
Mm.
Is there a future that with very minimal effort, robot only can do the surgery?
Yeah, that is an ethical dilemma. So many of the research it is directed in this way. So this is also a possibility. I am definitely not denying it. That is a possibility. But because of ethical consideration, I don't think that will happen in the near future.
Because anything introduced in medical, there's always a medical, legal and ethical angle.
Yes.
It doesn't happen like Amazon, Flipkart, whatever this immediately you can implement in the future. So medicine, you deal with the humans, there's always a medical legal angle and also misuse.
Yes.
And you are always like, you should not, we are not even, should avoid even 1% complications also, you should be answerable.
So all these newer modalities, whatever robot or anything, are better used if it's control. If the surgeon is having a control, then only it will have an added value. Definitely, if you give it a free hand, it won't be having a value what it is having now. So I don't think that will happen in the near future. So, but that is a possibility. I am not denying that.
So robotic surgery is one of the important milestone in the surgical history of urology, even cancer surgeries and knee replacements and other things. But there are many cases when you don't need robot, you don't need to spend the money, you discuss with the urologist and take action accordingly.
Yes.
So this is about robotic surgeries. And one more thing we are discussing, like this uroflowmetry. So any other common like investigative modalities where our general practitioners, other things are not aware, but which has a relevance.
Yeah, so uroflowmetry is one of the common tests which you need to get before evaluating a patient for prostate. So as I told, urine routine, ultrasound of the abdomen and uroflow are the three common tests which everybody should get for evaluation of prostate. So with respect to uroflowmetry, so the uroflowmetry is basically a machine which measures the quantity of urine which the patient has passed, the speed with which he has passed, and the average flow of the urine, all these things. So it gives a graphic curve. So based on that, we will decide whether it is an obstructed curve or a staccato curve. There are lots of curves. Ideally, it should be a bell-shaped curve. So for the GPs who are seeing, you have to look at around mainly 3-4 points. So ideal uroflowmetry, the patient should void minimum 150 ml. So the voided volume should be 150 ml or more to get a proper uroflow test. And you have to look for Qmax and average flow value and post-void residue. These are the 4 things which you have to look for in a uroflowmetry. Ideally, the voided volume should be more than 150 ml and Qmax should be more than 15 ml per second, and average flow should be more than 5 to 7 ml per second. So if the values are below this, it is called obstructed and needs to be evaluated with a urologist.
Okay. So thank you for valuable insights. We discussed so many things, starting from urological symptoms to kidney stones, kidney transplant, robotic surgeries, and many things. And this video is divided into many sections. People who want individual things, they can go individual video. Others, they can see the timeline in the single video and watch the complete video, whatever is required. So we'll catch up next time. Without you'll see the advancement. We'll catch up with Ravishankar. So thanks. Bye for now.
Thank you.
So now there is kidney stones are becoming very frequent nowadays, especially in summers. So there is a common urological complaint. People visit a urologist. I think so.
Yeah.
So that is like, suppose you told initially like flank pain is one of the symptoms. What are the common symptoms? Some are mild, some are severe.
Yeah.
So people with the kidney stones have.
So the most common symptom with which they come to us is with a flank pain. Severe pain in the flank starting here and radiating to the groins is classical of a ureteric colic. Along with that, they come with nausea, vomiting, dysuria, means burning of urination, passing frequent urination, and sometimes if the system is obstructed and infected, they also present with fever and chills.
Sometimes people have also hematuria, that is blood in the urine.
Yeah.
That also could be this one.
Yeah.
And can the some stomach pain with a burning sensation in the urine can be a symptom of the kidney stones?
Yeah.
It can be.
It needs to be evaluated.
So any of these things, evaluation comes to this. Normally people advise to go for ultrasound.
Yeah, ultrasound is a basic test available everywhere. So it is now considered a bedside examination. So ultrasound is the basic test to evaluate. But the problem with ultrasound is the ureter cannot be assessed sometimes because the bowel shadows come in between. So the ureter cannot be assessed. So, but for evaluating the stones in the kidney and the bladder, ultrasound is a very good investigation. And if we find some hydronephrosis in the kidney and ureter could not be visualized, then we suggest the patient to undergo a plain contrast CT. So plain contrast CT is the investigation of choice for all stones in the urinary tract.
So it's always a contrast CT.
Not contrast, plain CT is sufficient. Plain CT is sufficient for
because many people with the kidney stone also have high creatinine.
Yeah, that is one reason. So usually if the creatinine is normal and just to evaluate kidney stones, plain CT is good enough.
Good enough, okay. So like what are the treatment options? Suppose kidney stone can be inside the kidneys,
Yes.
sometimes inside the ureter,
Yes.
sometimes stones inside the bladder.
Yes.
So depending on the location, first is to locate where the kidney stones
Yes.
and number of kidney stones.
Yeah.
What are the common treatment option available nowadays and any like advancements?
Yeah.
So the treatment.
So the treatment of kidney stones depends on the size of the stone, location of the stone, whether the system is obstructed, the patient is having comorbidities or not. All these things contribute. Small stones of 3 to 4 mm sometimes pass by themselves unless the system is obstructed. So in these patients, these size of patients, we usually give a medical management for these size. So for stones more than 5 and above, so sometimes these can get obstructed. The common places at which it can get obstructed is the vesico-urinary junction, that is the junction between the ureters and the bladder. So otherwise it can lodge somewhere in the ureter, it can lodge in the pelvic-ureteric junction. So these are the common places where it can get stuck. So for sizes more than 6-7 mm, they are less likely to pass and they have to undergo some form of intervention. Over the last 10-15 years, lot of advancements have happened and we have got a very good laser systems available. So with minimally invasive procedures, we are able to treat any size of kidney stones without any cuts in the body. So there is a procedure called ureteroscopy, retrograde intrarenal surgery, that is RIRS, and there is another procedure called PCNL. These are some of the procedures which we commonly do. So the advantage with ureteroscopy and RIRS is that, so it's an endoscopic procedure where we pass a scope through the urinary passage, go near the stone and clear the stone. So there won't be any cuts in the body, there won't be any scar in the body, and it will be painless and recovery is very early.
And there are many people have recurrent kidney stones.
Yes.
So yeah, like almost like some people every year have kidney stones,
Yeah.
and some people have frequent procedure also. In science kind of thing, any blood test or urine test we can do to know the future risk of kidney stones.
So once you have a kidney stone means you have 50% chance of getting a kidney stone again. So ideally we suggest all people to undergo a ultrasound scan every 6 monthly. But there are a separate high risk group like patient having recurrent stones episodes per year, patient who are having metabolic disorders like hyperuricemia, hyperparathyroidism, hyperparathyroidism, and patients who are having family history of kidney stones, patients who are having a solitary kidney, or patients who have undergone transplant. These are some of the high risk patients who need to get evaluated routinely. So, and with regard to evaluation in terms of test, commonly we have to get especially in high risk patient, serum calcium total and dialysate, serum uric acid, serum PTH, and routinely ultrasound every 6 monthly is recommended.
Okay. And then now the common, everyone knows that drinking water is preventive for the kidney stone. And some people also, opinion that drinking beer is also good for preventing kidney stones. So is it a myth or is it really having any value?
So it's just a diuretic basically. Beer is just like a form of liquids. So any form of liquids for that matter, you have to drink at least 3 to 3.5 liters so that you are producing urine of 2.5 to 3 liters. If the urine production is between 2.5 to 3 liters, then the chances of crystallization and stone formation is less. Either you drink water, beer, barley water, juice, doesn't matter. So any form of liquid to make sure you are producing 2.5 to 3 liters of urine is the idea.
So if you are drinking occasional beer, it's okay. But that's not the only thing is you have to keep drinking beer to prevent kidney stones. And they should never try this in the acute pains.
Yes.
So you have acute pain, already stone is stuck in the ureter, then don't try yourself with the drinking 3 to 5 liters of water and having a beer, that doesn't work. Acute pain, you need immediate treatment.
Yes, so hydration effect is effective in prevention of stones. Once the stone has formed, sometimes taking steps like this means drinking lot of water and beer can be counterproductive and it can cause more pain, because if there is a big stone which is stuck, if you drink more water, more urine will be produced. There is no space for urine to go out and it will cause more pain.
This I've seen in my OPD practice also. Many come with a stone size. We say that they think that they always think that less than 6 millimeter will pass through. They go and keep drinking 5 liters of water.
Yes.
And they think that it will pass through. In such cases, taking opinion and further evaluation is essential. The hydration doesn't give immediate results.
Yes. One more thing, the size doesn't matter. I have seen people who have in whom 3 mm, 4 mm stone has also caused trouble. I have seen patients in whom 7 or 8 mm stones also they have passed. So size sometimes is not the only criteria. There are other criteria also. If the system is obstructed, even a 3 mm, 4 mm stone also will not pass. And also if the system is well dilated, sometimes 6-7 mm stones also pass. So size is not the only criteria. Better take the help of a urologist and come to a conclusion.
So this is one
Deciding
important
these
thing.
things.
Size is could be one of the criteria,
One of
but
the
it is not only the
Only
criteria.